Hi, good evening. So, thanks to one of the YouTube video watchers who had commented that I can use one of the hotkeys or the shortkeys to start and stop my recording without showing the OBS screen saver or whatever, see the portal of this OBS software. Thank you. I tried that. I went in the settings and changed, and this is my first recording using that. Hopefully, should turn out well. So, again, thanks to you for helping me out with that and suggesting me to do that. Always happy to learn technology. Being from the medical background, yeah, it's really difficult to get hang of technology when it changes and so many new things coming out every day. Anyways, today we'll be solving another SBQ. Uh, I changed one of the options in this SBQ because I realized that there was a lot of confusion in the options and probably this was not exactly how it was in the exam. There has to be some change. It cannot be so confusing. So I changed one of the words, which makes a lot of sense now when I read the options, and I will tell you what that is. Also, on another note, I could not take videos earlier. I thought I'll be shooting one every day. Since the last 3 weeks, what happened was I was planning to come home and shoot a video because in the morning it's just not possible with my son dancing around here and there. Monday, it rained in Dubai, okay, last Monday, which is like a week before. And there was some waterlogging that happened. Yeah, waterlogging happens in Dubai as well. So I didn't miss Mumbai much because in Mumbai you're like drowned till here if the rain happens. So though I waited properly and when the rain had completely stopped and I no longer could see much of the water logging as the rains were in the morning, I took out my car to go to clinic in the afternoon. I have a small car and I reached and there was only a very short patch where there was a little bit of water logging where I think my tires were half immersed in it. Now being a short car and a small car, I think somehow water seeped inside that electric fuse of the tires. So, anyways, I didn't realize all this, and I reached the clinic. I came back Monday, Tuesday, Wednesday. Thursday afternoon, I drove. I parked my car in the basement. And I went to the clinic and I finished working. I was back by 9 and I'm starting the car and it just refuses to start. And I'm like, wow, now what am I supposed to do? We call the road traffic assistants and they are like, oh, you have parked your car in the basement and we won't come in the basement. And my husband was traveling to Saudi and he was on his way back to Dubai and he was in the flight, so not reachable. And I'm like, I really don't know what to do. So then a couple of guys in the parking, I asked for help and we had to push the car up till the exit point where the road traffic person came and took the car to the garage. And it's been a week, okay? Not week, like Thursday, right? So today's Tuesday, yeah. So Thursday, Friday, Saturday, Sunday. Saturday, Sunday, the garage was closed. Monday. And now they are saying that the electric fuse is off and this is off and that is off. I feel so helpless without the car. And taxis are so damn expensive out here. So, anyways, it is what it is. ADC tagline, it is what it is. Manage. But one thing I was very thankful for, like when my car did start in the basement, the first thing I said was thank you, God, because it's the basement where the car is not starting. Just imagine if I was in the middle of the road and the car would have stopped. I would have been screwed royally because, wow, what could I do? And like I said, my husband wasn't home and my son was alone with the nanny, and I just wanted to reach home earlier. It was like I I mean it was easier, much easier in the basement. If the car had to stop, good, it stopped in the basement. So it's 11 years since that car was made. It's a 2013 model, and I bought it in 2017. I think it served its life. I wasn't expecting this big expense to come up because I just bought the Itero machine. Yeah, but you have to be prepared for emergencies. So, anything in life happens. I'm just sharing this incident that sometimes, whatever you have planned may not go accordingly, and something can just jump out of anywhere. So, anyways, on that note, expect some googly questions in ADC and just deal with it. Don't get stressed out. Okay. So, coming to the question, a patient came for extraction of upper 2/8. The patient on long-term corticosteroid medication, that's 15 milligram prednisolone for an immune disorder, allergic to bisulfate, has asthma, need to wait extraction. See, when you get a question like this, which has more of the medical component, what all things should immediately run through your mind? First thing is the patient is on a long-term corticosteroid. Now, what do you define as a long-term corticosteroid? Prednisolone, if given in a dose of more than 10 milligrams for more than 3 weeks, is defined as a long-term steroid. Why this is important to us? Because sometimes you have to double the dose of steroid to do any procedure. See, how it works is the body produces steroids, okay, which help us to deal with the daily life cortisol. Basically, it's our life going hormone. It helps us to manage the stress, the fight, flight, and fright response. Now, it is produced in a limited quantity. Now, due to some reasons, if you have to give an additional external steroid, then the body will lower its own production because you're giving an additional supplement of a high dose. Now, when the body lowers that, it's just the external steroid coming in, and you suddenly have a crisis situation, and dental extractions or any procedure is classified as a stressful situation. The body would not be able to produce the extra steroid because it's in a suppression mode, okay, because you're giving the additional extra steroid. So you won't be able to deal with the situation. Your body won't be able to deal with the situation, and hence you have to sometimes double the dose according to the procedure that you're performing. So when you read this line, long-term corticosteroid medication, this ears should shoot up, and you'll be like, okay, I may expect a question where it can ask, should I be doubling the dose of steroid or not, etc. Now there's an immune disorder also. They haven't mentioned which one. Allergic to bisulfate. Okay. So there's a preservative in local anesthesia which can be a bisulfate. But anyways, they have given this information. Let's see if the sub question is asking it or not. Has asthma. Asthma means he's also taking an inhaler probably, or you have to be prepared that whenever you are doing the procedure, the patient has an inhaler in case it comes down for him to use that. And you have to make sure that the patient knows how to use the inhaler. Okay, these two things you should be very clear, and you should make the patient actually show you how they will be using the inhaler, and you should take a detailed asthmatic history. Now, this can be your ADC Part 2 exam question as well, where you'll be given a scenario. One medically compromised question has to come, otherwise, what's an exam? And even in your day-to-day clinical practice, you may encounter, and so you should be well prepared because you should have the inhaler out on the table in case it comes down to using it. Just imagine the patient is having an asthmatic attack and you're all hunting in the purse. Where is the inhaler? Is it there or not? The patient is not able to speak, he's coughing, etc., etc. So the inhaler should always be present on the table, and the patient needs to show you how they know how to use it or not. Okay. So you ask this question to the patient if he's having asthma. Do you use an inhaler? Show me how you would use one. Since when you're using it, and when was the last time you had an asthmatic attack? Did any complication happen? What triggers your asthmatic attack? All these things you should be prepared for. Understand? Now, the patient needs to wait extraction. So let's see what is the sub question. Asthmatic patients can develop candida infection secondary to the use of inhaled steroids. Steroids by default will suppress your immune response. And candida is already present in the body, and it's an opportunistic infection. So whenever the balance goes haywire, the fungus grows. Now, how that can be managed? Decrease the medicine dose, change the inhaler, rinse the mouth after the inhaler use. Now decrease the medicine dose. You as a dentist are not licensed, or and even though you may be, you should not take the call by yourself to decrease the dose of the medicine prescribed to the patient for his disease or whatever problem they are having. Let the general practitioner or the specialist decide that. His life is more important than a candida infection happening in the mouth. So, decreased medicine dose is not the right option. Change the inhaler. Again, that falls in the bigger picture for the patient, and you are again not qualified enough to change the inhaler. So, don't do that. Rinse the mouth after inhaler use. Yes, the effect of the steroid right on the local part of the oral cavity, because you're inhaling through the mouth, would obviously be more, because more of the medicine is gonna get sprayed in the airway area and the oral cavity. So if you rinse the mouth, you are reducing the topical effect of the steroid. So probably the effects of the candida, or maybe the candida won't multiply and cause an infection proper, unless you don't rinse the mouth and let the medicine stay there, causing more of topical immune suppression. Understand? So out of these three options, logically also rinse the mouth after inhaler use makes more sense. Correct? Mm. Then we go on to the next sub question. How will you infiltrate the buccal and in which direction? So here they mean to wait. You are extracting to 8. To 8 is the upper left last tooth. And yeah, how will you infiltrate the buccal? For all the maxillary molars, unless you are giving a posterior superior alveolar nerve block, usually we tend to go apical to the same tooth and infiltrate in the mucosa. Uh, since we are just talking about one tooth and not a couple of maxillary teeth, I would go with the option of local infiltration rather than a posterior superior alveolar nerve block. If I had to remove three maxillary molars, probably I would go with PSA. But one tooth, why need the block, regional block? I can just infiltrate. So I'm going to go in front of 2.8. Now, in front of 2.8 is not a proper vocabulary. It should be apical to 2.8. But yeah, this were the options, and given in the exam, which was told to me by the other candidates, so I went with that. Apical to 2.8, it should be the right answer. The rest, you all are clinicians, you have given local anesthesia, it's a no-brainer. Like, so let's move ahead. Now, how to infiltrate the palatal? Now, see, there was a big discussion that was going on this question, because earlier I had given the answer that you should do it to the parallel to the long axis of the upper second molar. See, the reason I had given this answer was whenever you go ahead with the palatal infiltration of maxillary molar, in Malamed and other textbooks and everywhere else, we directly prefer to give a greater palatine block. Okay. Unless it's anterior to the premolars. Now, whichever molar it is, we always give it distally to the maxillary second molar, because that's the place of the greater palatine nerve. I have a picture out here. You see this? It's always distal to the maxillary second molar. It's not along the long axis of the maxillary second molar or along the long axis of the maxillary third molar. It's kind of in between these two teeth, but kind of distal to the maxillary second molar. Now, when you give that, the palatal mucosa of all this area gets anesthetized. Okay, but if I'm just removing a premolar tooth, I might just give an infill out here. I won't go directly here. But for the molars, what happens? You have to manipulate a lot of soft tissues out here and there, and the molars can get bilateral supplies from the other nerves, though infill also works fine. But if I have an option for any of the molars to go ahead and give it for the greater palatine, I would choose that. Okay. So yeah, in this picture, no, I don't think so. This is the right picture. Sorry, it's my fault. This is the first molar and this is the second molar. It comes distal to the second molar. There is a better picture available, I guess. Wait, let me just have a look. Can find one. Yeah, this looks fine. Yeah, this is the better picture. You see this greater palatine foramen, it's distal to the maxillary molar. Second one, forget the previous picture that I showed. I just went with the nice color thing and I didn't realize that it was showing distal to the first molar. This is the proper anatomy. Second molar and distal to it is the greater palatine, and like, but that previous picture was showing the proper anesthesia effect of the greater palatine nerve. So coming back to the question, how would you infiltrate the palatal? See, distal to the long axis of 2-7, according to me, is the best option out here. Let's see the other options though. Parallel to the long axis of the second molar. When I had chosen this answer before, my thought process was the question is asking just how to infiltrate the palatal. But now, when you see the sequence of the questions, I may or may not be right. They are referring just to 2-8. Now, in ADC, sometimes what they do is they give a scenario, but the sub questions are not matching with the scenario. The sub questions are just basic dental questions. Now, I had considered this sub question as a basic dental question, and that's why I had given the answer parallel to the long axis of the upper second molar for because the first option distal to the long axis of 2-7 was framed as parallel to the long axis of 2-8, something like that, similar to the option C, which was creating a lot of confusion. So I changed this option to distal to the long axis of 2-7, which is like a more appropriate option. So B, parallel to the long axis of upper second molar, is not a wrong answer, but I wouldn't choose that here. And so, all my enrolled candidates, I'm sharing this video to you all also. Please correct this answer in your mock. Parallel to the long axis of 2-8, again, is not a wrong option. For maxillary molars, if you just want to do an infiltration, you can. But like I said, the greater palatine block is preferred over just a local infiltration when you're extracting maxillary molar. Now, this is what I've read in Malamed. This is what I've asked a lot of oral surgeons. But even the option C is not wrong. Now, parallel to the long axis of 2-7 doesn't make sense because if I have the option of distal to the long axis of 2-7, I'm going to choose that. And I will choose option C over option D. Mesial 2-7 doesn't make any sense at all because I'm extracting a 2-8. So the correct answer, I'm going to go with the distal to the long axis of 2-7. But again, the option C is not wrong either. So you can choose either of the two options. Now, when you give the buccal and the palatal infiltration, the patient still feels pain. What other local anesthesia technique will be given next to a proper anesthesia? Now, here the options just mention intraligamentary. You can also have the option of intraosseous in your exam, which is not a wrong option at all. And intraosseous works better than intraligamentary, to be honest. And intraligamentary can get a little painful, but in intraosseous, because you've already given the buccal infills, it's not that painful. Intraligamentary also requires certain short needles and a lot of extra pressure for you to give. And in intraligamentary, you'll have to give the anesthesia on each root of the tooth. So I prefer an intraosseous injection. If the options would have mentioned intraosseous, I would have chosen personally. Uh, but we don't know what the ADC really wants. So if they have given the options of only intraligamentary and the options are mesial to 2-8, distal to 2-8, distal to 2-7, mesial to 2-7, or for the each root of 2-8, I'm going to choose each root of 2-8 out of the options given. But in your exam, if the option comes intraosseous, you can choose that. I mean, that's not a wrong option. See, such questions just test your clinical judgment. I guess one of these questions can be unmarked. Like they have 40 unmarked questions. It's not like they have 2 or 3 unmarked. 40 is a huge number, which means that 2 answers can be correct. So in this, if they would have given intraosseous, I choose intraosseous, you choose intraligamentary, both are correct. And ADC knows this, so they will just eliminate this question and not include this in the marking. You understand? So don't freak out if you find two very similar options which are correct. Probably that's an unmarked question. 40 questions are unmarked. Like I said, it's a huge number. So, yeah. And now, after you give all these injections, a patient feels dizzy, lightheaded, blurred vision. Patient was healthy and competent. His treatment on dental chair, after he getting up, he loses his consciousness and falls down. Okay, there is some vocabulary issues out here in the grammar, but basically what this question is trying to say, after you gave anesthesia, the patient feels dizzy and lightheaded. He was healthy and he completed his treatment on a dental chair. But once he got up, he lost his consciousness and fell down. I think a part of this question is missing. It should also should have mentioned that the patient then recovered soon after that, because the options that I could get from the candidates were its toxicity, syncope, or heart attack. Now, in heart attack, there has to be some radiating pain or something, or some history in the main question should have been mentioned, but not mentioned. So that won't be my priority. Toxicity, toxicity to LA will not result immediately in loss of consciousness. It can result in irritability, tachycardia, a lot of talking, palpitations, etc. Syncope out of these three options becomes my best choice. Now, in your exam, there can be further two options. They can be angina, they can be, I don't know what option they would like to give. But out of these three options, syncope becomes our best bet, as dizzy, lightheaded, and just transient unconsciousness are all classical signs of syncope. They can also give hypotension, or what do you call this, orthotopic hypertension. Now, if that option is given, even that can be the right answer. See, sometimes what happens when the patient is reclining on the dental chair and he's like almost in a supine position, and you finished your work and you immediately upright the chair and the patient gets up, there is not enough blood supply. The blood supply from the brain just suddenly gushes down because of the gravity, and you suddenly become lightheaded and you can fall down. Like, these symptoms match more to the hypertension than the syncope actually. So in that scenario, whenever you have put the patient in a very supine position, you upright the chair and let the patient sit there for a couple of minutes. And then when the patient feels okay, you can ask the patient to get down. So if orthotopic hypertension would have been given in the option, I would have chosen that as my answer because the symptoms match more of that. So yeah, read more on asthma. Read which inhalers patients can use in Australia, which steroid medications, what's a long-term steroid. Read healing in steroid, like extraction procedures, healing in steroid. Do you need to give antibiotics? Do you don't need? The classic $1 million question. Uh, Severely immunocompromised in a patient on a long-term corticosteroids, you have to give antibiotic prophylaxis. That is truly a prophylaxis. Prophylaxis means you are preventing more complications to happen. You want to prevent any sort of infection or complications or consequences. So when the immune response is already down, in a long-term steroid patient having immune disorders, yeah, you should be giving antibiotic prophylaxis. Then read more about the injection techniques uh, and whatever sub-questions were asked out here. The intraligamentary, the intraosseous, read local anesthesia, the components. Metabisulfite is the preservative, I guess. Read if you're going to use adrenaline or not in asthma patients. Yeah, this all you should be reading about. I have said all this many times in my videos. I'm not going to repeat. So there we solve one mock, and hopefully we're going to solve others and more mocks coming on the way. We already have 22 mocks. I think a couple of more mocks will be added very soon. Yeah, so practice, and I think now only less than a month remaining for your exam. Best of luck.